All right, here we are, team. It's game on. Time to stream. Talking about brains. Every Thursday night. That's what we do. So I can get this thing going. Changed back to an old one here. All right. Looks like Facebook is going. Looks like YouTube is going. Looks like... Don't you love it when I start and just look at this like I'm just trying to figure out a computer for the first time? Let's see. Let's take that off. That one's on. Cool. All right, let's play. So let's chat if you guys don't mind. So I know if I succeeded. There we go. Thank you. Ooh, this is a new name for me. Doru. Hello, hello. Welcome. Good to have you on a Thursday. I'm excited. Great day in the clinic today. It's a beautiful day outside. Nice fall day in Michigan. Nicholas, great to see you. Nomad over normal, as always. Love it. All right, we're going to play. So I put in a little... I was feeling a little spry, so I put in a little clickbaity title for you. Does your neck even matter? And that's a good question because this is a conversation that I get to have every day. Oh, we better get some good stuff in. Dennis has got kickoff. 20 minutes. What game are we watching, Dennis? Are we talking high school, college? Is there a program tonight? Thursday night? Maybe so. I don't know. I'm here. We are here. Amanda went for the emojis, but what I get on my end is hand pink waving. Love it. All right, Linda Ward, great to have you. Great, we got a good team. We're going to run strong tonight. So we're going to talk, as you might have guessed. Oh, Matheson's here, excited for tonight. I've been puzzled for so long by vestibular neck and neglect issues. So what we wanted to talk about is we've been covering so much ground in talking about concepts, trying to Eagles Cowboys, very nice. Wonder if you got a bet on the game. Sasha says hello. Anyway, we've been talking so much about Christy Lee. Megan, nice to see you. Oh, I keep interrupting myself. Sorry. Big Erms here. Tooth pulled out. Ooh, went well. Glad to hear it. Hopefully the smile still looks great. Roll call. Exactly. I got to make sure everybody's here, behaving. Peace, love, mung beans here. Great. Everybody's in their chairs, quiet, put an apple on my desk. It's great. Love it. Susan, hello. Okay, so I'm going to get actually to what I'm supposed to be doing. So we've been talking so much about concepts. I love that. I like getting deep in that. We don't really get that deep, but we get like deep enough, I think, for our conversation. And then we wanted to talk about, honestly, we spend a ton of time in the clinic, so there's not a lot of time to compile it, but what I want to show more of are some just examples of how these things work. Real people. I feel like that speaks to the world pretty well. And without kind of giving away their data or without giving away their story too bad, I just wanted to share some of them. And we'll start with one tonight and we'll just kind of keep rolling with that. I want to spend more time like showing you a little bit of what people have without necessarily like oversharing their story, if that's cool with you guys. Sound good? So where I am at is this concept of neck participation is really speaking to me this week for lots of reasons, I guess, from a clinical standpoint, from what we're seeing in the office, but then also some feedback that we get in our post calls. And then, I mean, this is ongoing, but, and then also kind of some of the things that have been coming out in the research lately. And it's kind of mind-blowing how little this is spoken about in terms of research. Like there's not much. There's some kind of adjacent things that express it, but nothing really that hits it head on. So we're going to try to just share a little bit about that. We'll talk about it, we'll go into the depth that you want. We'll take some questions. And then we'll just have a great little evening together. And then Dennis will get over to the football game. I don't know who you're rooting for. Hopefully it's a great opening night. Everybody stays safe, doesn't get hurt. Michelle says, hello. Big Erm. Hey, you know what? We don't do this enough, but I appreciate you saying don't forget to like the video. And that does really help. It seems like I don't know much about how YouTube works. I don't track it very well. Ginia gives me some great input, and I trust her a whole bunch. And that is like it. So, but I do know that the more people that see this, the more that learn about it, the more that talk about it, and we can make some moves in the world as far as getting people to understand what's going on. So thanks, Big Erm. Appreciate you. Congrats on the dental experience, as Michelle says. And let's talk about. So I was fiddling around with this here. I'm going to see if I can bring it up without any pomp and circumstance. Ready, set, go. Oh, it worked. Okay, so what is this? I know it looks like an eye chart. I will move it around and fix it for you as we're going along. Don't worry about trying to see it right now. You're going to hurt your eyeballs. But what we kind of did is took like a very quick snapshot of a tilt test and then a quick snapshot of a 10-day later tilt test. And this is on my mind because it's back to school time. And I love back to school time. I love back to school time because we get to like confront the angst of summer, if that makes sense. So a lot of people that deal with these particular problems are young. And so they're still managing a school life, which I think is wonderful. But there's a lot of angst about like, am I going to be able to go to school? And so this is the time of year where we're digging in, especially our college students are kind of already there and running. And we get to see like that reflection of the summer and where they're at. And it's really cool to be able to see them kind of taking on school and taking on that challenge. And for many of them, kind of thriving, kind of getting that under their wings. Because it never, you guys all, I mean, those of you guys all know this. Even once you start kind of getting back into your life, you don't feel ready yet. So there's a lot of like, oh man, hope we can do this leading up into it. And then there's deadline day and then off and running. And that's what this test reminded me of. So I dug it back up because we had a nice note. Scared money don't make money. Maybe she's here. And I just thought this was a nice thing to kind of walk us through a little bit of a clinical story. I'm not going to give much in terms of I'm not going to give any personal details, but we'll talk to you about what we saw, which I think is helpful. So this is from April. So it's been a few months. We're in the 4s. Now we're in the 9s. So call it 5 months. And just on the basics, like on the symptom side, it's the stuff you're used to hearing, right? So lightheaded, a lot of shortness of breath, big time shortness of breath, getting some PVCs, super uncomfortable. PVCs are preventricular contractions. So it's actually a heart rhythm problem too. So in addition to having POTS diagnosis, you also have this arrhythmia that comes in and it feels like skipped beats, super uncomfortable. And it also contributes to feeling lightheaded because as you skip some beats, obviously you're not pumping blood during that time. So it contributes and just feeling a lot of anxiety with that and just feeling bad. And most of you can relate. So on the front end, I'll walk you through it. And then this will give you a little sense of a little behind the scenes. Here's what we're doing during the day. Here's how we fill our days. Can I move this thing? Give me this. Oh, I'm on the wrong one. That's fine. Give me this. All right. Let me scoot it around. Try to make it bigger. Okay, so we'll start with it like this. Maybe go a little bit bigger. And some of you guys have seen me pull these up before or ones like it. But this is a really good, simple snapshot that's easy to show of what that tilt test is going to look like. So I don't know if you can see my cursor here. Hopefully you can, and my little head in the corner. Let's see. I'll move me down just a hair. Whoop. Ta-da. Okay, so over here, you can see this light part this is what we do in the test when we have you lay there for a little bit. Just get acclimated. We want to see just what life is like. And then this is the tilt portion. So in the tilt portion, 70 degrees of a tilt. So it's like standing and laying at the same time. And we measure these out through the minutes. Now you can see in this first one, we only made it to 8. So that we got an 8 count, standing 8 count, and then we had to throw on the towel. And you can see we've got some heart rate data here. We've got some blood pressure stuff here. This is capnography. Just think about this like the breathing section. And then the next part is the left and the right transcranial Doppler. Let me grab this thing. There we go. So, and that's just looking at blood flow that's coming into the left side of the brain, right side of the brain through the middle cerebral artery. And then obviously we're looking at some different variables in these. And then these are the subjective part is just like what people are saying while we're doing it. So what are we feeling? And so this I love a lot. So let's walk through it. Let me get back over here. So where I actually usually start these conversations is here in the blood flow region. Why? Because what does it take to get blood into your head? Well, good question. Glad you asked. Is you have to have a certain amount of blood pressure. If you can't generate blood pressure, the only way that you can get it into your head is to tip you upside down and hope that we can drain it into your head, right? So if you're going to get blood going upwards, we've got to have some pressure. And so we need some blood pressure to be able to push blood flow into the brain. Cool. And then how do we manage that? We manage that by constricting blood vessels, and we manage that by altering our heart rate and the contraction, like how strong the contraction is. Cool. So let's go back over here. And what we're looking at is real simply, you just want to think of, okay, these are our baseline mean numbers. These are great. 71, 74, rocking along. Laying down is crushing. And then what we're looking for is, though, in that next minute, we want it to be as close to this number as possible. So we want this number to be as close to 71 as we can, and we want 34 to be as close to 74 as we can. Why? Because all the cool stuff humans do is when we're moving and not slithering around. We wouldn't need arms and legs if that were the case. So we walk around, we walk on 2 feet. That means you got to be able to push blood upward. That means you got to be able to have some sensors that can feel if you're upward, and then be able to then fill the demand of pushing blood on up to the head. So hopefully that makes sense. So we want this number to be at least a 90%. This one on the left side crushes that, 94-ish%. But then we go over here to the right side, boom, 45.9%. So we'll round up, 46%. That's not great. That means we're losing quite a bit of that initial flow, especially on that right side of the head, right side of the brain. In that very first minute, we get a big drop. And we also see we get this pulsatility index that's really high, which means there's a lot of resistance to flow on this side that there isn't on the left side. And that matters a whole bunch, right? Cool. So by minute 2, we want to see, okay, can we at least hold it at 85%? Crushing it here on the left side. Right side, we've recovered a ton, which is great. We're not quite all the way home, but big recovery, boom, we like it a lot. And then as we track that down, we want the rest of these to be 85. We did that really, really nicely. And then, but over here, you can see we're hovering around that 85, 86 mark. And eventually we just had to, after this dual tasking moment, so we're doing the math in your head, count backwards by 7s. And at that moment, we just couldn't handle it anymore, had to come down, even though we had this decent response here. Okay, and then we can come back. We're going to look at the end tidal carbon dioxide, because for every millimeter of mercury we're dropping here, we're going to drop about 3 percentage points here. But we can see that's pretty reasonable. And we're low for sure. We're too low. We don't want to be there. But we're not to the point where we should be seeing this kind of a drastic drop on the front side. And then as a consequence, you slide back over here a little bit and you say, like, did the blood pressure drop? What happened? And we can see that it didn't. It rose the way it should, so that's good news. And then the heart rate, you can see, just cranked. So we went from a 77 to a 143 adjusted back down to a 123, then down to a 97, back up to 115, 99. So we get two things. We're cranking number one. And then this is kind of like, she spends a lot of time in this range anytime she's up and about in that 143, 123 range. Like that's her cruising altitude. But she's able to kind of cool it down, comes back up, cools it down, and then she's able to recover, right? So you can see like not the worst one we've ever seen in terms of like overall rates. It's a little bit different. What we're actually seeing is the big notable is just this huge drop on the front end, feeling lightheaded, weak legs, sweaty feet. And then, you know, obviously we had to pull her down, and then she recovered, slow recovery over here. All right. So that's interesting, right? So it's not, so we see a lot of cases that are just like big drops, bilateral, away we go. Here's a little bit different because we're seeing that there's this kind of one-sidedness to it. This right side is affected differently than the left. And then we can see that temporally it changes. So it's that initial movement from down to up is really provocative. And there's a big symptom base there that she doesn't quite recover from. Okay, so then we look from there and we sit up. So we sit in a chair, kind of like the one I'm in right now. Very similar to the one I'm in right now, actually. Swivel chair. And we still got the Doppler on. And we're going to look at if we're seeing changes with head movement. So seated, cervical, which is neck, range of motion, ROM, with the transcranial Doppler. And then where we actually note these, so what we're doing is we're going to have them turn and hold their head to both sides, flex their head down, tip their head back, stick their chin out, pull their chin back, tilt to the lateral sides like that. And then we'll confirm that by, so one of the things that we can't know is when we do that, if there's a problem, we don't know if that turning, that problem is coming because they got like a vestibular problem or their brain just like doesn't know how to do a turn very well and drops the flow, or if there's a problem in the neck and we actually restrict flow somewhere in the course from the heart to the head. So the way that we differentiate that is we do what's called a cervical torsion test, where we hold the head and then we're just going to turn the body underneath the head and keep the head still. And when we do that, the vestibular system and the ocular system is not moving. It's not active. So we're just straining the neck. Now, that might mean that there's a structural component to that, but it also might mean that just the proprioceptive barrage, which is like the feeling where you're at component, that can be enough to screw you up too. So it doesn't fully differentiate the structural component, but it does help us understand if the neck is a contributor. And we're looking for 20% or bigger changes, and you can see here, so right rotation, turning that to the right, decreases flow rates to that left side by at least 20%. And we noticed up here that that wasn't really like the big concern, but actually we see the pretty good cut when we're doing a head turn. Left rotation does the opposite. It decreases the right hand side. Flexion decreased the left hand side. Extension decreased the left hand side. Right lateral flexion decreases the left hand side. And then we see with the cervical torsion that the turning to the right decreased the left side, and the turning to the left decreased the right side. So we see that there's this kind of like something's up with these head turn components, because these are messing with her too. And that's really important because that's also part of this shift between laying down and standing up is the loading of the head on the body, okay? So that part is really, really helpful. So when we're looking at this, yes, we're looking at autoregulation, we're looking at vasoreactivity, we're looking at this screaming high heart rate, but then there are these clues that help us understand like this movement of the head is really a kicker for her. And it turns out also that we could kind of get a yield on being able to instigate those PVCs by doing head turns. So I can listen to her heart, have her move her head, and you hear the arrhythmias come in, okay? So I'm going to leave you hanging for one moment. That's like the starting point. I'm going to leave you hanging for a sec because I got some kids here at the door and we're going to say goodnight. It is school night time, so we got to get them to bed appropriately. Get in here, you. Did your brother and sister bail?
Nick's playing with his car. He's going to come and sit.
Oh, okay. Well, now is our moment. So come on over here and give me a hug.
Nick, now is our moment.
Love you, baby. Did you guys have fun riding the car?
Yeah.
Okay. You can go to bed?
Yeah.
I'll come give you a kiss on my way. Okay?
Okay.
Okay.
Love you.
Love you,
Good.
baby. It was good?
Yeah.
How'd you do that?
It's on this like plastic thing. You can't see it. It was right there. It was bleeding.
Really?
Yeah.
Okay, we'll clean it up and get it fixed up. Okay. Love you, bud.
Love you.
Okay. Did you all shower, you bunch of stinkers?
I'm not stinking.
Oh, sure you are.
Daddy. There's a phone right there.
Okay. Love you. All right. You close the door for me. Can you close the door for me?
Yes.
Okay. Thank you. Thank you for that. I got a little tighter time moments now that we're back in school. We got to get them to bed. All right. Ugh. Okay. So a couple quick questions. Cameron, I see your questions. We're going to get to those. Cool. Because they're a little bit deeper. I'm just going to handle some of like the technical ones right quick. So how do you determine when you take the measurement? We do them at the defined periods of time. It's constant measure as well, but we clip these so it's easier to kind of show people what we're up to here. So Sasha had asked, this is an important point. She had a 26-minute time frame. So we, as in our tachycardia cases, what we're looking for as like primary tachycardia, one of the things I'm looking for is we're going to find it in that first 10 minutes because we're going to see the response to the movement. Now, we will elongate that test when people have a history of fainting, or they have a history of orthostatic hypotension, or they have a clinical syndrome that looks like it's hypotension. That triggers a different change in our protocol, and we run it differently at that point, and we have it set up so we can run it longer, and we're looking for that breaking point. But in the tachycardia cases, we typically find that those happen with a pretty rapid onset, or we see a decay in function over that time frame. So that's a good question. And then Linda had asked, is the test you're referring to similar to shaking your head for bilateral hypofunction? Can that be connected to dysautonomia in the neck? Absolutely. Vestibular hypofunction is a predominant part for a lot of people, especially if you're noticing that dizziness. But when that test is actually a little bit differently. The head shaking test, we don't do a lot of because it's a little overwhelming for a lot of people. But basically, you're having someone turn their head back and forth, and a lot of times you're either trying to maintain a fixation or reading a word set. But it's hard to actually detect this. The way we look at it is more through a head thrust, where we put video oculography on so we can measure the eyes, and then we do a thrust of the head so we can see if there is a saccadic intrusion. They're different beasts, but they do link up in terms of that central vestibular system and how they talk to one another. The docklings. So urine reports cost large amounts of tilt data. You collect and try to find patterns. Right now we're still collecting. We don't have a team big enough to run the studies yet, but we just collect the data in hopes that we'll be able to kind of accumulate that later. Okay. Who locally do you ask? Oh, that's a tough question. That's why we're here, is because honestly, I don't know, and there's not a lot of people. But that's why we got to talk about it, so we get people excited about it, so then they will also do it. So I don't have a great happy answer for you there. It's probably more like I don't know. But that's why we are here. Let's spread the word. Let's get some more people doing it. Cool. Okay. So let's look at the tail end of this here. Okay. Cervical instability is a big component. We'll talk about that more. Celeste, because there's different ways to think about this. Is it primary instability where we've got a primary injury or a primary problem? Is it secondary as a compensation to another problem in the spine or in the vestibular system? What's going on? So they're not all painted the same, and we want to figure out how do you solve that for each person, but it can definitely affect it. But it makes sense to hunt for that a little bit more, understanding why and what's going on. And sometimes we have to be careful of that because some people will have like a objectively diagnosed instability or like kind of a subjectively assumed instability, and we'd want to think about those slightly different. Okay, so this is the post one. First thing that jumps out at you, we made it 10 minutes, so there's a big win. That's pretty fun. Yeah, so she was a struggle bus on this one. Now, this is 10 days later. That's not very long when you've been dealing with this for a long period of time, right? So 10 days later, working hard, and primarily working on things that revolve around this neck of hers and the stability of being able to control it, as well as just the simple structural posture underneath that. So those of you that are laughing because I'm a chiropractor talking about necks, I get it. But in this particular case, that's where we're at, is we're thinking about her neck. So just rerunning the test, you can actually see the mean values are lower, but they're still actually in a really beautiful range here. And then, so we're not getting these big, huge peaks, which is kind of like we were hoping for a little bit, because if we're cranking it up through there, sometimes we're looking at a higher resistance rate, and that forces that value up. So even though the overall value is low, it's still in this beautiful sweet spot for her age. And then you see these nice responses here, where we're not having that big latency drop. Numbers are all in the 90s and 100s, which is wonderful. We've clipped up these ETCO2 scores a little bit. They're not cranked all the way up yet, but we're seeing them start to trend up. And then we're happier with the blood pressure. And then you can see we're still having some of this spike, but we're like 20 points less on a spike, which is cool. So even though we're still getting some of that, it's coming down, which is really cool after 10 days. That's awesome. And so the reason I like pointing these out is, like, I don't want to show you these to be like, look at how amazing it is. This is so cool. But what I want to show you is what it actually looks like in a person. Like, this is what they go through. And at this moment, they're not like, she's not like, I'm doing great, I'm all better now. She is like, I've been putting in work. This is hard. We've been working at it, but I've got something to show for it. I can see my needle is moving, right? And then we look over here and like starting to feel a little bit of something, feeling good, getting hopeful. This is the time in the game where everybody gets a little nervous because they're like, I'm feeling real hopeful. Things are moving right. I'm scared it's not going to work. What if it goes back? Starting to feel a little better. Don't want to feel terrible again. That's a very common sentiment. But that's just where we are. And then you can see here in all the ranges of motion, she cleaned them all up, which is crazy. So all of these were roughing it, and then she didn't pop any positives on the second time around. Huge win. So when I see that happen, I get real excited because I know we got a real good shot at one of these. And then so she has been just working like a crazy woman over the summer. Not working entirely. I got a nice video of her enjoying herself in a great way, which is super cool, going out and doing some fun stuff. And so I love seeing that. Thank you for sending that if you're out there. Hopefully you're not. Hopefully you're doing something that you shouldn't be doing in college. But, and yeah, so then you get to see, like, because at this moment, like, we're riding high, we're really hopeful, but then we're also, this part is like, I feel all the feels because I feel really good because this is happening. But then we get in the feels of like, man, I'm turning over the reins. I don't get to control this perfectly when they go home because it's in her hands. You know, she gets to be the one that decides to do these things every day. She's the one that's got to stick with it. I am giving it up, which I don't love doing, but that's part of the gig. And so there's a little bit of wait and see. There's a little bit of, okay, where are we going to stumble? Can we make the habits? Can we get them to stick? Can we see where the weak spots are going to be? How's it going to go going forward? So I think that's like a relatively honest appraisal of like how these cases tend to look. And some of them way miracles, some of them slog, right? But that's just the nature of it. So this kind of cuts through the middle, but it really speaks to the importance of what we primarily worked on here was a lot to do with two pieces, and I didn't show you the other one, but this cervical component, and then the component that comes with that was the fact that we actually had this cervicogenic nystagmus, which is wild. So we did some things to address the vestibular integration from this. So we know if we slide back up here that we're getting some problems with the head turn structurally, but also with the way she's managing that from a proprioceptive end. So we had to do things that were structural, right? Be able to have it so that she could shoot the blood into her head, but then also be able to recognize where her head is through that central vestibular system. So it's this melding of these two different types of presentations that I think are really important, because on my perception from where I sit is that there are a ton of people walking around with pictures that look just like this, because I see them constantly. But because this isn't on the forefront of what people talk about, just don't even know to look at it. And then like nothing that you're going to do from teasing out chemistry standpoint or your diet, which you've done, like those things are all great for general health, but on these, that's not going to solve this particular problem. And so I just want to bring attention to that. Not saying that that's what everybody has or this is how everybody should be treated, but we should at least be giving it a look. And especially for those people that kind of fit that role, because there are so many of you walking around in this state that that we need to give a completely different strategy to. So that's what I was really interested in this week. That's what I felt called to talk about. So I hope that that's useful for you guys, just seeing some of the data points and seeing how they change. And they change remarkably quickly. But I will point out this idea. So I get this conversation a lot, which is, okay, I got the blood flow back in my head. I should be rocking and rolling now. And it's like, well, kind of. But also, you've got to get that blood flow in your head and you've got to let it heal. So there's an amount of healing that has been compromised along the way that needs to come back in. And then some integrity built out in this system again to actually make it stronger. So step one is like normalize it so that you can just get oxygen and glucose and all of the chemistry that you need back into the brain so that you can start to build the strength back in. And I think that part, part's super important to kind of keep in mind, is that's like first step, we got to get it there. And then we can start to get stronger after that. Okay. So thanks for your attention on that. All right. So what is she doing to make those positive changes? So here we're using manual therapy as a way to help her kind of understand where her body is in space. So we're doing proprioceptive exercise. We're breaking that all apart, and then adding back in activities with head and neck movements, eye movements, whole body rotation activity, and then also using some low level exercise to try to help with the capnography component. So we get a feedback of that capnography and we do our exercise through that lens. And so she spent a lot of time doing those things, which is really great. So I'm glad that helps. Okay. Yeah, I didn't. So in these ones, no adjustments because she's bendy. She's one of our extra mobile people, right? So one of the things that they talked about was this hypermobility, EDS, GI stuff, venous laxity stuff. That's part of this conversation, like it is for so many of you. What we found is that, so one of the things that has to happen is if we have this, if we have this hyper kind of kyphosis in the neck where we're super slouched here, one of the ways we have to make up for that is by altering some of the joint mechanics in the upper cervical range. Dr. Katz out of Colorado did a really nice job explaining this in a paper and kind of showing this, which is cool. And so with that, we can get this like compensatory hypermobility. So everybody got really excited about the hypermobility, but lost track of the rigidity and hypomobility in other places. So what we try to do is spread that back out and normalize the motion across the whole system, which was useful for her. So they were exercises in that sense. Not any chiropractic manipulation on this one that I can remember. Maybe I'm wrong, but I don't think that was a big part of it. I think we did some ribs for some of the breathing moments, because shortness of breath was such a big component of this. Where did that go? Visual balance interventions. So we use whole body rotation as a way to stimulate that inner ear along with the neck to tame that nystagmus and bring it down. And Linda asked, the neck can impact nystagmus. Yeah, usually we think about nystagmus as primarily a vestibular problem, which it largely is. But if we affect proprioception in the neck that is then fed to the central vestibular nuclei, then we can see that bleed through where we get nystagmus in certain motions with head and neck activity, which is really important and often overlooked. And when I say often, like way often overlooked. Okay. Okay. So Carol wanted to know, how do you see orthostatic hypotension and internal jugular vein stenosis potentially impacting one another? It's a good question. So orthostatic hypotension is where we're dropping blood pressure. Dropping blood pressure overall is going to tend to drop cerebral perfusion at a certain point. Internal jugular vein stenosis is going to basically mean that we're blocking off the drainage system of the brain. So the pipes that go down, you got a clog in one of those pipes. If it's C1 involvement, usually means there's rotation in that upper joint in the neck, which can compress that internal jugular vein and decrease the rate of drain. Now, two things to consider. There can be collateralization, because it's bilateral. So if you've got enough space for it, it can drain to the other side, and a lot of people can do that. You'll find that we'll get MRAs and MRVs where people will just have congenital like hypoplasia of some of these like transverse venous areas. So some of the veins that go from side to side draining the brain, some of them will just be, they just don't have them or they don't develop correctly or whatever, but they do fine by draining just on one side. So that's kind of one part of it. But yeah, those are kind of two things that don't go together, because usually we think of that backing up flow and then creating more tension in the system. So what would be interesting to know is if you've got that C1 involvement in a person, what is that C1 involvement in terms of not just including the jugular vein, but how you're orienting to where your head is in space and how that may impact the orthostatic hypotension. So it may be a problem that's not specifically all structural, but in the neurological component as well. Eileen, I hear you. I see you down there relating to this, and I knew that I would get that from you. So my encouragement to you. Good to see you. Okay, Mathieson, could you explain again how to figure out if you want to do a vestibular treatment first or neck treatment? As assess your head, turn your head in the body and keep looking straight ahead. Not entirely. So we're looking to see how they're involved with each other. That test, the cervical torsion, tells us that movement of the head and neck impacts the way that your brain is going to shift its own blood flow into the head, but then also getting some structural changes with that movement as well. So it's a little more complicated. And then we want to see if there's a predominant vestibular pathology that is affecting output of the neck, or is there a pathology in the neck that it's affecting the vestibular system, or is there a problem in where that information goes in the hub of where it gets integrated, right? And is the problem there? Or do we have a combination of how these things are affected? And those tend to happen more in head injuries. So in this particular case, we see the nystagmus, rather than differentiating one versus the other, we said, let's run this neck because we can't get anywhere. So I kind of start from the position of, in neuro rehab, I really don't like to stimulate the brain if I can't feel comfortable with the amount of oxygen and blood flow that are coming into those areas. It makes me more concerned about exceeding the capacity that they have, about pushing them too hard without enough ability to be able to take in that stimulus and respond to it because it doesn't have enough fuel. So I will tend to set the priority more toward, can we stabilize the fuel and then be able to use that as a way to then stimulate the rest of the system. So that's kind of the way I'm thinking about it in this particular case as well, where I'm trying to do things that first augment blood flow, because that gives me way more latitude to throw more things at her to stimulate her brain without feeling like I'm going to overwhelm the system and potentially cause a problem. So we start off in that pathology, and then once we see we're making a little edge there, then I start trying to integrate them together, because this neck and vestibular component, they are one and the same. They're part of the same team. So hopefully that helps. Where am I here? Okay, CJ, thanks for saying that. Leah Bowersocks, welcome, welcome. Good to see you on the stream. Made it home. Okay, Genia's doing a little housekeeping. I'm going to jump back a little bit because Cameron had written a note that I said I would get back to. So I'm going to try to find that. And then we'll continue. I'm sure I probably missed some stuff, so I apologize, guys. Oh, Cameron's got a theory. Let's hear it. Ugh. Exercise has been hailed as the gold standard for recovery, but POTS patients generally aren't reconditioned to begin with. I'll agree with that. Is exercise a means to expose our system to a hypercapnic environment, at least relatively higher CO2 than baseline, to improve chemoreceptor component? I like that thought process. And I would expand it beyond just looking at the CO2 levels. And you could think about this writ large with whatever you're trying to solve for. So whatever the crux or whatever the problem is in the system, that's what you're trying to do, is you're trying to create. I'm going to give you guys a word. I made a video about this week, but it probably hasn't come out yet. I'm going to give you a word that I think is going to be useful in this community, and it's called allostasis. Allostasis, some of you might be familiar with the term homeostasis, which is like keeping your internal environment steady, right? So your pH is always pretty tightly regulated, pretty much the same if the system's working. Your oxygen levels, CO2 levels, they're all pretty much the same on the inside. Your temperature is pretty much the same, right? So we keep them in these really tight constraints. So what allostasis is allostasis is the body's ability to deviate from homeostasis. Because the reality is like at rest and everything is just cool, you can, like, resting is a lovely part of life, but it's not like the active part of life. If you've got to eat, you can't just lay there and hope that the food lands in your face. So you have to be able to expend energy to be able to do things. Yes? So that is allostasis, is how much capacity do I have to mobilize the energy in my body, to utilize the systems, to be able to push my body outside of rest. How far can I push it outside of rest effectively? So, for example, you might have like a football player, Cowboys-Eagles game tonight. They can rest, their heart rate's super low, the body's relaxed, everything is really easy. But they can also get up, sprint down the field with just a bucket of muscle on them and just create a violent hit on the other side of the field, mobilizing a ton of energy, right? And then they can slow down and stop and rest again on the sideline. And then that allostatic load pulls back down again. So that ability to have the flexibility in the system to go from rest to activity is allostasis, the ability to mobilize energy toward a demand. So when we're thinking about neurorehab, that is what we're doing. And we're saying what we're actually measuring is the inability of a portion of this system to be able to go and meet that demand, right? So if that's something in my neck, when I do something simple like turn my head and all of a sudden, whoa, I don't know where I am, and it sucks a lot of energy out to try to figure out where I am. Now, something that is considered to be a pretty small input is generating a large load. It's chewing up a lot of battery to do a simple thing. And then my recovery from that is going to be a little bit lower because I'm not very good at doing it. And so what you're trying to solve for in all these cases is reducing that allosteric load, or the recovery time, and you're trying to be able to increase the capacity. And that doesn't matter if you're working on a neck, doesn't matter if you're working on reflexes around baroreceptors, doesn't matter if you're trying to make it so that your eyes work normally, or that your inner ear detects where you are, or you understand where your arm is in space. In all of those instances, you're trying to take a thing that takes way too much energy and operates poorly and turn it into something that becomes more efficient and operates well, so that when it's plugged back into the rest of the machine, you can do more things. And that's kind of like the head and neck of it. And Cameron, I really like the way you're thinking about that, because that's what you're speaking to, specifically in terms of hyper and hypocapnia. And there's some evidence that supports that, but that may not be for everyone. But certain people, that is the thing. But all of the thing is figuring out what is kind of that edge for you that we need to boost up again. So thank you for that question and bringing it out. I really love it. Okay. Larry Lester, total neck and spine fusions. Woo. Problems ever since. Larry, I'm sorry to hear that, man. Yeah, when we get to fusion, it's kind of like putting your spine in a big cast. So as you know, and I'm not picking, I'm just trying to use this as a way to communicate with everybody else. Whenever you decrease the movement in that system, that movement is kind of how your brain charges and understands where you are. I think about, like when you're young and you're sitting with your lady or your fella, and you lay your arm over here, but you don't want to move it. It's like the old Brad Paisley song, and it falls asleep and you kind of don't know where your arm is, but you got to kind of wiggle your fingers to find where your arm is, right? And that's what happens, but at a larger scale in your spine. So when it doesn't move, our brain kind of doesn't get the feedback signals of where we are. It's not pinging back and forth. And so we start to lose that proprioception. So people will notice that because they can't feel where they are in space, and we lose all of that beautiful motion. So I know usually the only reason to do this because you're in a ton of pain usually. So I can understand, the risk reward of that. But I think it is a good share for everybody else here, and understanding that maybe you don't get a full fusion, but maybe you just, like, a couple segments don't move correctly, which can yield a similar outcome for people. So thank you for that. Okay. How are we doing out there, guys? I'm going to get a drink of water real quick. Hopefully everybody had a good holiday. My wife gives me a hard time because this is a former peanut butter jar, so we're really classy over here. And I didn't bother to fully get the label off. And this is my drinkware. So there you go. Nice glass. I love it. So let's see, Jesse Miller. Welcome. I've been having orthostatic hypotension and blood pooling since trying to quit caffeine. Interesting. Trying to bring it back, and now exasperates severe adrenaline. Is this normal when neurotransmitters get thrown off? Yeah, caffeine's a bummer because it's so delicious in the form of coffee. I don't know what your demon was, but yeah, it can be hard to get off. And a lot of people will notice, especially with cerebral blood flow problems, which is kind of where you end up with orthostatic hypotension, is that caffeine brings all the stuff you don't love, with like the shakiness and the anxiousness, and amplifies that system in a major way, which it sounds like that's kind of what you're talking about when you say adrenaline. So yes, as you're changing the sensitivity of the receptors, it's pretty common. Unfortunately, sorry to hear that, but hopefully with whatever you're up to, it helps you be able to work through the hypotension part, and we can solve that. Give it some time, get stronger again, and then you'll probably find that your tolerance to those things gets better. But when you're struggling a little bit, caffeine can be a thing that definitely points out your struggle. So don't feel bad about that. But it doesn't mean that it's something that goes forever. But in the short term, you might feel better without it. For that it's worth. Okay, so Matthias wants to know, we were talking about that allostasis and capacity and metabolic capacity specifically. So what happens if you exceed that capacity and treat someone's brain that isn't getting enough blood? So if you're well trained, this is how we all learn. So like the I would say one of the greatest focal points that I got in the early days of learning neurology with Dr. Carrick was this concept of metabolic capacity, which means you can only push something just beyond what it's currently capable of in order to make it grow. You can't push it super hard or you'll actually injure the tissue. And you can't push it not enough because it doesn't create a change. It doesn't give a challenge or a response, a challenge that creates a big enough response in the system. So what you're aiming for is you want to challenge the system, but just a little bit, so that it can recuperate and recover and get a little stronger, and then do it again, and then do it again, and do it again, and do it again. So most of what our training is actually recognizing the fatigue points in metabolic capacity. And you can see that's part of what we're looking at in exams. So like when you do certain things with dual tasking, does a pupil get big, or does your eyelids start to close, or do you get to where you don't speak as fast, or does your face, do you kind of start to hold your mouth open? Does your heart rate go up? Do you start to sweat? Do you start to have a little shaking in your eyes? So all of these things are things that we're constantly evaluating while we're working with people, so you don't walk away. We're like glued to people like this the whole time, and we're looking for these little subtle changes, then we stop. So I'm very much aware of trying to make sure that we're not over capacity. I look at trying to solve for the cerebral perfusion as a starting place because it means that you can push them more. So if we can get them to where we have a higher capacity level to start with, because they're actually getting irrigated, you're getting blood flow, then it gives us more space to actually push people rather than just taking these little micro increments and hoping that we don't push it too far. So it's not a thing that I get scared of. It's a thing that I think about in order to help people as fast as possible and make sure that we're seeing all of those variables. So I look at blood flow as a major part of that. It's a good question. Do I see... Hello, A. Dyer, 421. Can't see your picture exactly. Alexa asks, do you see dysautonomia in mal-de-debarquement syndrome patients? And we do. Mal-de-debarquement in the classical sense, for those of you wondering, it's disembarkment syndrome. So it used to be kind of solely correlated to travel, boat travel, air travel, car travel, where you have a persistent sense of motion after you get off. And some people will notice this for a short time and it regulates, but in this particular case, it's chronic. It lasts for a long time and it's not going away. It usually feels a little bit better when you're moving. So like driving the car actually helps you feel better. That's kind of one of the classic signs. And we'll notice different physiologies of this in different people. Some people will have highly vestibular pathology where we see this decoupling of this vestibular component between the otoliths and the visual system, right? So that's kind of one common one. But another one we'll see is where we just see this rapidity of square wave jerks where the ability to inhibit them from kind of the frontal cortex down into the superior colliculus and then down into the pons, that little group fails. So it can be for different reasons. But in some of those cases, we'll see, especially those ones that affect that brainstem component, because we have that sense of motion, you're going to get a ramp up of activity in the autonomic system, which may overfire or overmobilize energy in that system. So we do look out for that for sure. And that is honestly one thing where some people will come in with MDDS, and then we talk about dysautonomia as a secondary part. And like, did you know you also have this? And then sometimes people will come in with autonomic problems and we'll point out like, well, this is actually a variant of MDDS, and we talk about that, and we look at that Venn diagram crossover. So that's a really good question. So a little tie-on for Matheson in the question was, and it looks like it kind of got popped in a couple times. I understand what you're saying about the neck and vestibular being connected, and that the neck can block blood flow, but what I'm confused by is what I keep getting the advice in general to only treat one system at a time. One of my theories is that the neck is blocking for blood flow, and that's why vestibular treatment isn't working. I found neck treatment that relieves my lightheadedness, but I've been holding back. Oh. I'm combining it with my vestibular exercises because of the advice that doing one system at a time. Sometimes that's a really good point. Sometimes that will be the advice when there's uncertainty about how to approach it. So by doing one thing at a time, you can measure one thing at a time, and then you're less likely to, this is like a more scientific way to approach it because you can see what happens. And that's fine. That's one of the choice a lot of people are going to make. Without knowing the case and knowing exactly how to approach this, or giving online advice, I think it's really interesting that the neck treatment is helping. So if it is helping, I would be interested in seeing to what degree it's related to the vestibular component, if there is one, and how those interface with each other. And then look at how do you start to let them do that on a normalized basis. So you're always trying to get everything to you're pretending like you're trying to get back to like running around like a kid. And so, or that's the way I think about it. And so if you're trying to do that, you have to think about, well, I want to live a life where I can move my head and my eyes at the same time as run around and laugh and chase someone. So you have to be able to integrate all these things together. So at some point, once there's enough strength in that system, then we want to be able to drive that, if that makes sense. Okay. One second. Okay. Oh, when I do that, it takes away. There we are. Okay. Hi, Denise. Practical. Glad to help. Piece of Mungbead had said allosteric loads. So allosteric loads is slightly sound a lot alike, don't they? This is more like, if I remember right, I might be wrong, but I think allosteric load is talking about protein receptor function. I might be wrong. I have to go deep into biochem on that, but that's what's ringing a bell. But they sound very similar, but I'm pretty sure that has to do with like protein shape. I don't know why I'm answering that because I don't know exactly for sure. But it's a word that sounds very similar. JB, can you talk about what you can do for people who have had a fusion and maybe experiencing dystonias? Okay. So with a fusion, we start to think about because we have a limitation of matter. Once we have a fusion, it's like, well, okay, we can't, that's not going to function normally again. So how then do we operate within the new rules of that game? So if we got new rules of that game, it means that we need to have other receptors overcompensate for what we've lost in that segment. So it means that everything else has to be dialed in terms of the motion of that system, the way that those muscles operate together, and then how that correlates with vision. So like, do we need to overweight vision so we dominate that more? Do we need to overweight proprioceptive activity from different areas, or increase vestibular sensitivity so that they can take up for the change? Because obviously some people can have a fusion, and they do relatively okay, but the difference is how well those other systems are able to compensate for it. So that's how we start to think about solving that problem, is walking back and seeing where can you get the most bang for your buck in terms of adding some more sensitivity so that we are not being impaired by that one particular segment. And this is something that happens a lot. You're asking about it specific to dystonias, which where you're going to have an angulation. And a lot of times those angulations are because we see changes in the feedback loop. And when that change happens, we expand the somatosensory map. And what that means is we start to blur that picture in our brain. So the hand's the easy way to think about it. So my brain has a representation for each finger, but it also represents each joint and all the different movements. So it has a lot of variability, and I have little spots in my brain over here that allow me to be able to detect that, right? So I can feel all those different things. But the way we think of dystonia is that now we start to blend these things together and they move en bloc, which means they all move together. So even though I'm just trying to move my pinky, I might move the other segments as well. So it becomes less specific and more generalized. So what you're trying to do is see if you can split out those movements enough to differentiate them again and see that brain be able to specify that map again. So changing the feedback ratios there. Yeah, I know that's like conceptually I do it, and then you think about what is the best way. Can I use a retinotopic map using eyes, and can I combine that with cerebellar activity? Can I use proprioception, or is that blurred together too much and I have to stay out of that? Can I use visualization? Can I use manipulation? So it depends on what works and what doesn't. So it's hard to give a generalized scenario there, because some people do really well with eye movements and some people won't. And some people do really good with local feedback on that segment and some people don't. And some people do well with mirroring or watching the inverse of that on the other side. So if I've got a dystonia in one arm, can I do things on the other side with my eyes to help to remap this side? So that's where you get into more of the nuance of exactly how to do it. But the overall picture is thinking about that map, and is it becoming generalized where everything's moving together, it's all linked, or are you able to maintain that specificity where everything has a freedom of movement? I love this name. Oh no, this guy. God, love it. Hello, long-time watcher, first-time chatter. Great to have you. Great to have you chatting. Thanks for all the information. Appreciate it. If I ever have a question... Oh, nope, here it is way down here. If I were to go to my primary care doctor with these symptoms, what professionals would I ask him to see? Fantastic question. Some of that's going to depend on where you live. If you're in the U.S., then a starting place is usually going to be the cardiologist and the neurologist. And then to what degree that's useful to you, I don't know for sure, because that's pretty individual on the doctor you get. What I hope, if you've been watching, is that maybe some of the things we talk about here may be jumping off points to have a conversation with some of those folks to figure out how they can be useful. Now, you could also go a secondary route and look at people that are functional neurologists, although not all the same. Just not everybody's at the same point in their career. Not everybody's at the same point in training, same point of focus. So there are going to be different skill levels associated with that. But those are at least people that are thinking kind of in the lines that we're talking about here and may be able to either help you directly or continue to move you in the direction of help. So, but getting going somewhere is better than nothing, because then at least you're going to get the chance to iterate and kind of make moves and probably kiss some frogs, make some mistakes along the way, but that'll help to be able to navigate towards something that's useful. So my advice, even though you can take it for what it is, but would be to start pursuing some help, learning more, and then the faster you can move, the more you can figure out what works, what doesn't work, and then you can keep going forward and find your way. So hopefully that helps. Okay, where did I go? Eclectic skeptic. Have you ever heard of or treated Bethlem myopathy, which is a type of muscular dystrophy? If so, do you find a correlation or causation between that and autonomia or autonomic perfusion issues? That particular form of muscular dystrophy, I am not an expert in. So I don't think I can give you I don't have a wonderful answer for that. I apologize, but that's the honest truth. I don't know specifically how that looks. I could look into it for you, but I don't know that correlation off the top of my head. Okay. Eileen says, I can see how nudging it just a little at a time is making stronger, but it's a slow process. It can be. And everybody's got different limitations and different starting points. And I want it to be like I'm competitive, so I want it to be just a fast fix for everyone. But the reality that I also have to be aware of is that if we can keep people moving forward rather than standing still or sliding backwards, then you can get to where you're trying to go as long as you keep moving forward, right? So as long as you're making some progress, even if it feels slow, that's still a miracle when you put the person at the end of that journey next to someone who's stuck at standstill, stuck at go. So it's never fast enough. If it takes, a year, that's not fast enough. If it takes 2 weeks, that's not fast enough. None of it is ever going to be fast enough. That's my perspective. But I love seeing people working hard and just keep going, keep getting better, keep moving forward, and eventually you get to the line. You get to the finish line rather than thinking of how hard it is to be at the starting line of a race or a marathon. Let's put you at the starting line of a marathon. And at least if you get going, you'll get there and you'll get to the end. But if you don't cross that starting line, all you do is just look out at how far away that finish line is, and it's so daunting. But as long as you're in the race and going, then it gives you something to focus on, something you're controlling, something you're moving forward to. So that's not necessarily specific to Eileen. That's just kind of the way I've been feeling about this lately, the thoughts I've been having, the conversations in my head, because we, thinking about this all the time. So thanks for saying it. Mel, been diagnosed with AS, ankylosing spondylitis. Have you come across any problems with people on TNF blockers that have an uptick in POTS symptoms that may correlate? We do actually see some people that have AS specifically in those inflammatory markers, and then obviously the TNF blockers as a way to mitigate that. I don't necessarily know that the blockers themselves are the correlate, but anytime you're looking at a medication, there's a potentiality for irritating the autonomic system because it's tied so closely to the immune system. So there's always potential there. I can't speak to that directly, for you or try to treat it online, but that is a question worth asking. It may be good to dive through some of the literature on your particular med and see what some of those side effects look like. You've probably already done that, but it wouldn't be abnormal, and it wouldn't shock me to think about that. But also, just that particular disease process in and of itself is a largely inflammatory process. It's happening in an area of the spine where you're flirting with some of the inferior most portions of that sympathetic output, as well as starting to get into the parasympathetic component down into the sacral plexus. So definitely probably worth noting. Did I talk about CCI already? We talk about CCI all the time. Craniocervical instability. Today we talked about it in terms of we were talking necks today. Feel free to jump back earlier in the conversation, but CCI is a super common question, super common problem, and one that I love to work with. But you want to know, what are you working with? Not all CCI is the same. What ligaments you got problems with? Are they busted? Are they stretched? What's going on? Is it actually a response, like a positive response to hypothermia function or decreased movement in another area. So we're just seeing that as a compensatory reaction. Is there an injury versus something that is acquired in a different way? Those things help you figure out how to solve for it. And then sometimes you're also thinking about just the reactivity of the motor system or the muscles in that area. If the reactivity is slower, there's a high latency, you're more likely to yield your end ranges of motion than you are if you have muscles that are highly responsive and kind of hold everything within their normal range regardless of the soft tissue load. I will make a comment. I'd like to make this comment. We should talk a little bit about the role of collagen in this process, because when we're talking about these soft tissue disorders where we're worried about basically these collagen structures having too much laxity, and on the outside of that is the thing that allows them to be able to generate that tension or the rigidity and stability is the load, is the piezoelectric load. And so there's this concept, like there's interest. So Japan is working on these, I think it was in an airport, where they're building these piezoelectric floors. And what it means is that when people walk on it, it puts pressure into the floor, and that pressure into the floor is an energy exchange, right? So you're pushing down into the floor. And when you do that, you do generate an energy transfer in the form of electricity. And so what they're doing is they're using that floor, and they're trying to harness that piezoelectric activity to be able to use the energy, like a solar farm, right? And they're using that to power the building, which is pretty slick. We do that. So the collagen in our system is meant to load, is meant to have that rigidity against itself. And the actual tension creates the piezoelectricity and drives into these collagen systems, which is beautiful. So the irony, or maybe the paradox, is that one of the things we need to do to adapt collagen structure is to load it. And I know that is like a very fearful idea when it comes to people that have hypermobility. But actually, in order to stimulate the tissue, we actually have to put it under some degree of load. Now, how we do that matters. Do we need to do it intelligently? Yes. But it's a concept worth holding in our heads as we think about that relationship of head and neck activity, how that may be impairing vascularity coming up, proprioception coming down, and how do we create that integrity through those proprioceptive and musculogenic systems. So very cool stuff. Maybe we'll do another one on that down the road. What system do you use for TCD? I mean, the best idea for that is to go like investigate and see which one you love the most. I don't know that I want to give a recommendation on that, because I want people to. I don't know that I want to shill equipment. I mostly want to just focus on, can you get the measurements? What cervical collar to test if they get relief? What the blood flow changes are you using? Yeah, so I use all sorts of different stuff. So I'm hesitant to give a prescription on that, because I don't feel good about that. But Dolphin's a good system. There's another system from WS Medical. There's one that is there's one from Multigon. So they're all great systems. It just depends on what you want to use it for. Depends on what your budget is. You could, if you want, maybe we could get you in touch with one of our favorite equipment distributors, and they could help you. So maybe Ginia, maybe you could help me out there and put them in touch with Matt, and we can figure that out. But I'm just hesitant in this setting to go into that. Okay. My neck treatment, Matheson, my neck treatment is working, but only for a day or two. I'm considering it could be a good idea to test if my vascular exercises will finally start to have an effect if I do them in that little time window where the neck treatment's working. That's not a bad strategy. It's not a bad idea. I like the way you're thinking there. And then we can also see if the cervical component is actually secondary or compensatory to the vestibular part. So if you've got a vestibular error that's being compensated with the neck, we may do things with your neck that in one sense help with the blood flow, but also decompensate what's happening with the vestibular system, right? So I'll back that up and so everybody can hear it. So let's pretend I've got a vestibular problem. Like my central vestibular system, something's a little off. I got rattled, and as a consequence, when I move my head, I have a latency. I don't pick it up as fast. I have an alteration of my eye movements to try to compensate. And then because those are off, my neck is going to go into this shunt stability. I'm going to get a cervical colic response. So my neck's going to tighten up. So usually when we have a vestibular disorder and then we're moving, your neck's going to tighten up as a response to that. And then let's say that maybe there's a problem in the neck to the point where that neck tightening up is restricting blood flow. So now I'm in this unique position where when I do things with my neck, it helps alleviate some of the blood flow problem, but it will also take away my compensation for this vestibular problem, so I might punch up some of my symptoms there. Bummer. So the way we have to think about that one is we want to be able to temporarily be able to create some perfusion so that we can do the vestibular exercise and then get the response of having that neck normalize its function. The neck is compensatory. It's doing what it's supposed to do based on the reaction from the other symptoms. So it's a way to be able to integrate them together. So I like the way you're thinking there. Ruben, could a vestibular issue cause POTS and dysautonomia symptoms? I have seen that a time or two today. Yeah, that's a good question. And yes, for sure, I think it's very, very much worth looking into if you're dealing with those types of symptoms. My 2 cents. Yeah, sorry, eclectic skeptic. I wish I had more to give you there, but I don't. Thanks for asking anyway. Okay, so, oh no, this guy, new first-time caller, said, been to the cardio doctor, only thing he could think of was vasovagal syncope. Could be, but you can test for that. So you can look at a tilt response and see, do I have a drop in blood pressure, perfusion, heart rate, what order does it happen in, and then you can work from there. So that while vasovagal is like a place to start from, then the second part is let's get some data points to see what's failing and how. Let's throw in a deep breathing test and a Valsalva test in there to see if those loops in the reflexes are intact too. Cool? Let's run it. Let's do it. Oh, my thing changed. When are you going to open satellite clinics in Atlanta and other cities? Specifically Atlanta, huh? I don't know. Satellites are tough. Satellites are tough because it's hard to keep an eye on everybody and be able to teach everybody well. But wouldn't that be a dream? Okay, I'll go check with the neuro. Maybe neuro, but also maybe let's dive into a little more testing to see what's going on that vasovagal part. Cool. Follow up on a neurologist and rheumatologist. Mel, good luck with that. Let us know how that goes. How do all these questions you just posed get answered? Sorry, Denise, I didn't catch what questions. I was probably rambling and didn't catch this, so I'm not sure what I was talking about. Hopefully it was real smart and sounded very elegant. I don't remember where I was when you asked that one. Sorry, Sasha. I find my fight or flight triggers often without cause. With treatment, is it possible for that response to return to a normal state when it fires when you truly need it, rather than seemingly random times? That's kind of the goal. Yeah, that's kind of the goal of treatment. And a way to think about it might be like, hey, maybe my body is throwing up this signal and it's doing the right thing, right? It's like when you've got a well-trained dog and it comes and lets you know somebody's at the house and you're like, I know. but they're doing it anyway, right? Because that's what they're supposed to do. And your body's kind of like that. It's doing it because there is a problem. So we don't necessarily look at that like, bah, even though it sucks and we hate it, but it's also like, okay, it's probably doing what it's supposed to do. If so, what is it? Why is it reacting that way? Or if it's purely reacting just in a hyperreactive way, are there other things that are hyperactive too? And then how do we start to pull that down? But the question you asked about, is it possible? Yeah, it's super possible. Yeah, Susan B, that's the, if you find a neurologist that specializes in dysautonomia, they may know more. They may, it's, I hesitate to say that with all certainty, because it's just going to depend on who you see. But the more specialized, hopefully that gets you a tighter direction. What do we got here? LFC. I use a neck TENS unit for cervical neck. It heats up, helps calm visual system problems from TBI every time I use it. Interesting. So we know that there's probably, well, not probably, we don't know, because I don't know this case, right? But that's an interesting bit of information in terms of if you can alter an input into the neck and it alters visual outcomes, that's pretty cool and something worth definitely leaning into to the nth degree as much as you can. Mathis, in your question, how can I find out if that treatment is working temporarily on my lightheadedness because of improvement in proprioception or because of relieving structural pressure on your on blood flow? You'd have to measure that. Easiest generalized way would be to look at it in like a duplex ultrasound. You could do that. It might be harder to get somebody to do it, but you could do it. Or you might have to think about it in terms of another way to strip it out and say, like, I don't know, and maybe I can't know given the tools I have. But you could look at that neck treatment taking gravity out of the situation. So if you say, okay, I can get my neck to work, and then perhaps I can do those vestibular activities in a way that doesn't stress the graviceptive system, so you could do them rather than, I don't know anything about what you're doing. But for example, someone might say, like, this gaze exercise I'm doing while seated, I could modify that and do it while laying down, and then I don't have to have the system also be able to manage blood flow at the same time. I can work on that vestibular system under a normal load, laying down, and then work my way back up again. And then I don't have to try to contaminate the two. I can try to just work on the two separately and put them back together. And that might be a way to think about it. It's just like breaking the two systems apart, scaling them back down, and working them up separately, then back together. Okay. I was talking about the various causes of CCI. Yeah, you got to get somebody that just loves it, Denise, and then learn from there. So there might be some testing you can do in different provocative positions. People like to use digital motion X-ray, flexion extension CT, flexion extension X-ray even, to be able to look and see if there's any noticeable alteration in spinal segments, and then you can kind of look deeper. You can get a reconstruction CT as well and get a sense of, like, a basic sense of just structurally what's going on with the CCI, and then you overlay that with a dynamic exam where you're looking at the function of how those things actually affect outputs in the neurology of the system. I love these names. May I just add that? Asked, hello, doc. My worst dysautonomia symptom is pre-syncope. I feel as though my head is not getting enough blood. Blood pressure is hovering around 90/105 max. I'm assuming that's top number systolic. Constant flight or fight. Where'd you start? What a question, huh? Okay, so where I would start. I don't know that I'm going to get that done in this setting. Would love to know more, but that is probably where I'd start, is in the data collection side. We got to know more. Go back through and look at some of the other ones. Ginia, the one we did on the POTS diagnosis and kind of walking through the stages, maybe that would be a good link for this one. And then may I just add that it might be a little extra homework But we did that live. I think you might like that one if you didn't see it already. And that might give you a more linear way to look at it rather than me trying to ramble it off here. So if we could get that link, or you could look back through the live streams, it's like this 4 steps to diagnosing posture, something like that. It's very crafty, wonderful tagline, but it was probably a couple months ago. Maybe Dr. Ginya could help you with that. Okay. They're probably the ones that get you some tilt testing. Yeah. Actually, I think usually we end up doing that at the cardio. How do you know if you should do gait stability exercises but modify it so I'm laying down and perhaps doing it slower? Or if I go the other route and just start combining neck treatment with the vestibular treatment? I think you want to get somebody that has some confidence in how to do this. And I would probably look at how they link together. We're getting too nuanced here. We're getting too much into your case for me to be able to, like, I can't give that advice here. I'd have to actually see it to like tell you how to do it. So I don't want to give you advice. I don't want to give you advice that would be wrong because I didn't actually look at this thing. Okay. So, I don't know who you're using, but if you've got a good resource, this might be a really good question to start digging into. What is the take on the cost benefit of apps and phone games? Do they actually benefit the brain more than they disrupt everything else? Great question. Anything that you do beyond just kind of sitting there hanging out and like not working your brain's probably good. Do you want to be on your phone all day? Probably not. Can you get outside and, get your toes in the grass a little bit every moment that you can? Try. But if they are, things that make you smarter, go for it. You also can go to the old classic paper Sudoku and word searches and all that stuff as well. But things that just challenge you and force you to focus, pay attention, use your working memory, those are generally a force for good. Okay. Dr. Genia coming through again. Just a round of applause for Dr. Genia on it as always. Always crushing it. Always kind of keeping an eye on what's the pulse of the room. Not just in the live, but just in social media in general. And she is super helpful for me in terms of being able to know what do people need me to talk about? How can we serve people? And so thank you for that. Because if it were me, she would tell you, I would just go full nerd mode, and we would just be pulling up research paper after research paper. Don't threaten me, because I will. But that's not what is the best service of everyone, so I want to do that. Okay, it's 9:30. This feels like a good end point for us tonight. We crushed it. We got a lot in there. Really, if you could please think about this in terms of this neck activity, how that integrates with your brain. I know we love the brain. Let's talk about it. Let's think about the neck. If you got people in your groups, share it with them. Here's the deal. Share it with people to find out where the counterpoints are. See where people want to argue with you. And then that way it helps us understand, what do we know? What do we know, and how do we start to think about it? Because that's going to give you more ideas too. So once you grab a little bit of knowledge and you feel like you command it, like go check it against someone else and see where they give feedback, and see where you can kind of wrestle with that, whether it's with a doctor or whether you got a friend in a chat group or whether it's a relative. And that'll help you to be able to assimilate what we're talking about more, and it'll help you know where to look and what to find. But I want to encourage movement. I want to encourage movement forward. Let's keep everybody moving forward. So when we come back next week, it should be with everybody has done like just a little something, even if it's small, just to push the needle forward. It may not mean that you feel better next week, but it may mean that we want to do something that helps you do better next week. And I'm going to take this one last may I just add that? One more, please. I hear CCI stories that are so depressing. In your opinion, do they need prolotherapy or can exercise help? Even with the prolotherapy, most places that do that are also using a form of corrective exercise. Most of them are using chiropractic CBP. Chiropractic biophysics is a way to help that. So you're going to be doing it anyway. All the prolo does is just kind of help to close off some of those gap junctions if we've just got some holes there. But if we've got tears or we got other things, may not. I love prolo's great, but you're gonna be using some form of an exercise with that also. Random stuff. Names tonight are awesome. Are you ever able to help people with MCAS, even if POTS is not present? For sure. When we think about that as a hyperactivity within that that immune system or in that allergenic system. Cool. All right. Love you guys. I really appreciate it. It's good to be on the live again and getting in the groove. We're gonna continue to push the needle on showing you guys some evidence of what we're doing, because I want there to be a library of that. And then we'll start kind of building out some more concepts as we're going. We'll start adding into our conversation some new ideas. So